Hello students, I am Dr. Rohan Vasanth, Assistant Professor, Department of Periodontology, Vinayaga Mission Sankaracharya Dental College. Today we are going to see about the topic called as peri implant disease and its management. So let us move on to the topic. Today we will be seeing about the contents such as introduction, classification, definition about what is peri implant diseases, prevalence of the diseases, risk indicators of the diseases, diagnosis, treatment plan, and furthermore upcoming details. So moving on to the introduction part, so we will also see about in recent days there are many implants has been practiced among the practitioners. In the implant conditions of the things, there are many kinds of implant failures also has been indicated. The main reason for the failures may be due to the improper hygiene maintenance of the patient, an improper prosthetic part of the prosthodontist, and upcoming other conditions involved also. So major conditions involving in the peri implant disease are biological complications involving the host factors and the patient's idea about what is implants and the maintenance of the implant conditions around it. The main bacterial biofilm is the accumulation of bacterial biofilm around the restorative components are the osseointegrated implants parts will be like in disease conditions also. Moving on to the concepts of ailing implants and failing implants. Ailing implants is nothing but there will be like a radiographic evidence of bone loss for probing depth more than 5 millimeter, but after re-evaluation of every 3 to 4 months the implants will be healthy. But in failing implants you will be seeing about the probing depths and separations and bleeding on probing and with the progressive bone loss also. So we will see about the classifications of peri implant diseases. So how to evaluate the peri implant disease? Firstly we will be going for the redness, swelling and bleeding on probing evidently. In redness and swelling if they are present, then the condition will be like of diseased condition. If the redness and swelling without any probing depth, then we will be going for the healthy conditions of implants. So we will all seeing about the peri implant in health and with the recorded bone loss, and peri implant mucositis and peri implantitis. So what is all these things? If there is no any kind of inflammatory condition, then it is called as peri implant in healthy conditions. But if there is no signs of inflammatory condition with the evident amount of bone loss, then it is called as peri implant in health with the recorded bone loss. The inflammation is like confined to the gingiva, it is called as peri mucositis. If the inflammation is involving gingiva and the bone, it is all called as peri implantitis. So moving about the healthy and the disease state of peri implantitis, as we discussed earlier, there are certain clinical signs that is involving erythema, swelling and without any no bleeding on probing. These kinds of conditions will be signifying the peri implant health. But in peri implant disease condition, it will be going for inflammation around the peri implant surface with the mucosa and progressive supporting bone loss. So you will be going to the difference between the natural tooth and the dental implants. In natural tooth, you will be all seeing about the PDL ligaments around the tooth surface with the cementum and dentin and enamel surface completely. But in implants condition, we will be seeing only the gingiva part and the supporting bone around the tooth, which is also integrated around the dental implants. So because of this condition, the rate of progression of the diseases around the PDL ligament is like slow, but the rate of progression of disease around the peri implant condition is like comparatively fast than PDL infection states. So what is the pathogenesis? The alteration, the homeostasis between the host response and the bacterial component leads to the peri implantitis condition. It may take weeks or months for the implant to develop any peri implant or infectious conditions also. So moving on to the microbiota responsible for the peri implantitis, we will be going to see a broad categorization of red complex and orange complex bacteria, mainly involving aggregatibacter, actinomycetum comitans, staphylococcus aureus, enteric rods kind of bacteria and candida albicans. Mostly we will be focusing on the gram negative anaerobic bacteria, which are the main reason for the peri implantitis disease around the implant structures. So moving on to the histopathological conditions, in PDL infection conditions and in peri implantitis condition, we will be seeing about elastases, which are less amount in PDL infection, but in peri implantitis, which are like in more amount. The inflammatory infiltrate are focused towards the connective tissues. In implantitis, we will be focused towards the bone, and in main reason for the infection of interleukins 1 alpha, we will be seeing in PDL infection. In case of peri implantitis, we will be seeing about TNF alpha, mainly focusing on TNB T lymphocytes beta cells. So moving on to the part of risk indicators, we will be seeing about the local factors and the general factors also. Local factors are involving improper oral hygiene maintenance, foreign body accumulation, periodontal health, and soft tissue conditions without any pocket, roughness of transmucosal surface involving the implant surfaces also, and implant prosthetic connection problems. In general factor, we will be seeing about the history of period infection in the patient who we are going to place in implant prosthesis, and genetic factors and acquired factors such as diabetic, and environmental factors involving smoking, alcohol consumption, and stress. Moving on to the etiological factors, the remaining teeth around the implants will be like causing a period infection are such as there are like a prior bacterial load amount is high in the period infection persons, which will be more treatable or non-treatable state for the reservoir of microorganisms. So whenever there is a patient is having a prior history of period infection, the patient must primarily managed with the infection and then going for a rehabilitation of tooth. If they are going without any management, then the rate of chances of implant failures because of peri-implantitis are very high. Moving on to the next factor of diabetes, it has been proven the fact that with a HbA1c value of more than 10.1, the patient will be having a higher chances of failure. Next factor is about smoking. It has been proven that by Valovi et al., a 4.7 times fold increased rate of implant failures has been seen in the patients with a smoking condition than with the non-smokers. And with the same as the concept of alcohol conditions, but in alcohol conditions additional to smoking they will be having about 6 times more implant failures and conditions. The upcoming factor is also oriented towards smoking and alcohol consumption, which is called as stress. But in stress we will be seeing that the stress is not directly involved in any kind of implant failures, but it is the factor that the psychological behavior because of stress leading to the improper brushing techniques and the improper brushing conditions also, which involves the stress related smoking and stress related drinking causing the implant failures. Moving on to the implant surface characteristic, whenever there is an implant surface roughness, it must be polished or maintained. If it is not polished, it will be paving a way for the bacterial deposits to deposit on the surface and causing any kind of abnormalities or any kind of infections around the implant, leading to the implant failures in futures. And types of suprastructure is like there must not be any kind of gap present between the prosthetic part and the implant fixture. If there is a gap because of ill-fitting prosthesis or excessive cement, these kind of conditions lead to the deposits of calculus or microorganisms growth on the surface, leading to bone loss and exposure of implant threads, causing furthermore deposition and implant failures. And submucosal foreign bodies not only involves of prosthetic part, it also involves about excessive cementation. If there is like an abnormal excessive flow of cementation into the prosthetic part, it will overflow and it will be like impinging on the gingival surface, causing gingival bleeding and other kind of inflammatory part, which will be leading further to the infectious conditions also. Endodontic infection, same as that of the infections of PDL, the endodontic infection involving apical region or apical part has chances of infecting the implant fixture once after it is like osseointegrated also, because the same organisms of orange and red complex are involved in the microbiota. These conditions not only involve the implant failures accumulation also, in the oral cavity surrounding the structures are also involved properly for implant failures. And the presence of keratinized mucosa plays a major role in sealing of the implant surface with the help of gingiva. This prevents the further accumulation of bacteria and other kinds of organisms on the surface and leading to the further loss of collagens around the structures, causing implant failures. Or if there is a non-keratinized mucosa or if the mucosa part are like completely removed, it will be more vulnerable for the implant to get infected very easily. Moving on to the part of diagnosis, there are 3 major conditions of diagnosis can be followed. First is like transgingival probing or bone sounding. Second will be like involving of radiographs, and third will be like using an instrument called as perio test, that is used for implants, whether it is mobile or not testing. Moving on to the peri-implant mucositis, it is now we have to see the difference about the peri-implant mucositis and peri-implantitis. As I informed earlier, whenever there is an infection is like confined to the gingival part, it is called as peri-implant mucositis. When the infection is like involving gingival part of the implant and also going inside the bone and causing progressive bone loss, it is called as peri-implantitis also. So in implantitis condition, there will be leading to the future failures, which are like categorized into 3 major conditions, that is early implant failure, late implant failures, and implant which is failed already. The failed implant can be because of pain and functions and uncontrolled exudate mobility. Bone loss is like more than half the length of the implant. And early implant failures because of surgical trauma, overeating of bone, insufficient bone volume, and perioperative functions. The late implant failure, which is mainly caused due to prosthetic part. Once the prosthetic part is like placed, causing loading conditions, quality or volume of bone and peri-implant level is like very low, which in the condition can be differentiated between the bone loss and not bone loss conditions also. Moving on to the severity state, it has been categorized as mild, moderate and severe. In mild condition, we can see the pocket depth like more than 4 millimeter. In moderate, there is like more than 6 millimeter. In severe, we can see about pocket depth of more than 8 millimeter. In conditions of bleeding and exudate, there in all the three categories, it is like evident with a bone loss of 25% in mild and 50% up to is like moderate, and more than 50% is like going for the severe conditions. And in probing, as I mentioned already, this transgingival probing mentioned by Lang et al. Has been like used properly. If the probing depth is like 3 millimeter, it is normal in healing implants. But if the probing depth is like more than 5 millimeter, it is be going for the peri-implantitis condition. In normal condition, till 3 months, the probing depth should not be done, which will be like impinging the healing tissues and impaired healing can be seen. Moving on to the part of exudate thing, an evident pus flocculation or active deep lesion causes peri-implantitis in the condition, which must be avoided in whatever cause it may be. And moving on to the mobility, there is an instrument called as perio test. It has been used to check whether implant is mobile or not, depending upon the three variants of categories. First variant will be going for -0.8 to -0.1. In this condition, it is considered as implant is well osseointegrated. And second condition is like 0.02 plus 0.9. In this condition, the clinical examination is very mandatory to do to check whether the implant is like diseased or not. And third condition is like +10 or higher, states that the implant is mobile and it must be removed or further treatment must be planned accordingly. Moving on to the radiographic examination, we can see two kinds of radiograph are used here. First is like periapical radiograph is like used, and second is like digital subtraction radiograph. If these two radiographical technique has been proven clinically to find out whether the implant has been like affected or implantitis condition is evident or not. And the third is like bone defects has been like found out with the help of this kind of diagnostic factors. And there are four major categorization. First one is like horizontal, class 1, which is like a single kind of vertical defect can be seen. Second is like key-shaped defect, where the vertical defect is circumscribed around the implant surface on in one side alone, and funnel or gap-like, which is like categorized into class 3 A and B. In this condition, the tooth surface either buccal, lingual or buccal and palatal, both surfaces are involved properly, circumscribing the tooth, but the bone loss is like only up to the half the length of the implant. And in class 4, it is like a complete entire length of implant length is the bone loss is there. So the complete implant will be like mobile, and removal of the implant is the only fact to be done. This bone defect is given by Javanovic by 1990 and Spikerman by 1991. Depending upon the bone resorption. And now we will be going on to the part of treatment. There are certain pre-surgical protocols should be followed before the implantation. Pre-surgical medications involving antibiotics and other kind of mouthwashes and ultrasonic scaling or non-surgical methods of cleaning the teeth to prevent the penile infection from infecting the implant surface should be done. And furthermore, the surgical method and implantoplasty are like advised for the betterment of the implant surface also. So in conditions of goals of therapy, the first one is like main rule is to removal of the bacterial plague. Second is like decontamination and conditioning of the implant surface. Third will be like involving the reduction and elimination of the site, which is more vulnerable for deposits and leading to the pocket formation. Fourth will be like efficiency of plaque control. Fifth will be like the regeneration of bone. And going for the treatment planning condition in peri-implantitis, we will be segregating the treatment plan according to the pocket depth. First will be like the pocket depth of less than 3 millimeter, whether it is like absence of bleeding on probing or evident bleeding is present. If the bleeding on probing is like absent, then we will be like going for no treatment or not treatment is like evident. And second will be like evident bleeding on probing will be going for a non-surgical maintenance of cleaning or scaling is like done properly. If the pocket depth is like more than 4 to 5 millimeter or up from 4 to 5 millimeter, it will be leading to the treatment of additional to the ultrasonic scaling or cleaning with the help of antiseptic cleaning or irrigation must be done. And third category is like more than 5 millimeter of pocket depth. This can be subcategorized into no bone loss or more than 2 millimeter of bone loss or less than 2 millimeter of bone loss. If there is no bone loss, then the normal non-surgical method of cleaning and irrigation is sufficient. If there is like less than 2 millimeter of bone loss, then you must go for local drug delivery using perio chip or fibers can be used, and more than 2 mm bone loss must be going for resective osseous surgery, and regenerative approaches must be followed for the safeguarding of implants. Moving on to the part of non-surgical thing, the partial reduction of plaque and bleeding scores after the mechanical curettage is proven by Person et al. Up to 30 to 40% of peri-implantitis inflammation has been resolved properly. So, a dry saline irrigation with the proper cleaning of the implant surfaces causes a more than 40% of reduction of inflammation is like evident. And secondly, like using a steel curette may damage the implant surface because of the material made of it. This is called as titanium. So, properly formed curettes such as carbon fiber curettes, Teflon curettes, plastic curettes are used in these conditions. And third is like ultrasonic devices with the plastic tips are advised properly. Additional to that, implant debrider has been used to remove the deposits around the two structures. The plastic curettes must be made of polyether ether ketone coated tips, and which is a high plastic material with a steel core, so that the implant surface will not be defective in any kind of conditions. Moving on to the titanium pressure has been recently involved, and it has been previously exposed on 60s, but recently approved by the government or any kind of associations. That the titanium pressure treated site has been proven that 66.7% of non-treated site and in less inflammation has been absorbed properly. And moving on to the air powder polishing, using a material called as glycine and erythritol, using an instrument of perioflow nozzle, the implant surface has been cleaned with a high pressure sand blasting technique, so that the implant surface will not be mobile or any kind of thing because of the human pressure. And moving on to the detoxification using chemicals such as hydrogen peroxide and sodium hypochlorite, hydrobenzene has been like properly used, and we can see there are like different percentages should be used according to the needs. First is like in hydrogen peroxide, the concentration of 3% is like only allocated. In ETTA condition, only concentration of 2 minutes and 4% is allocated. In citric acid conditions, only 30 seconds is like allowed. In phosphoric acid, 35 to 40% is like involved, and sodium hypochlorite we can see only 0.1 to 1.3%, and chloramine 0.95% is like allocated. So if the allocations of percentage has been altered, this causes a chemical burn in the tissues and the chemical structure modification of implant surface also. And moving on to the mouth rinses, normally chlorhexidine and betadine mouthwashes are used properly. Apart from this, the cetyl CPC has been used properly. In this condition, we can see a better or a good oral condition, or resolution inflammation has been absorbed properly. Moving on to the local drug delivery or a systemic and local drug condition. In systemic condition, the medications such as azithromycin, amoxicillin, clindamycin and metronidazole are absorbed properly. In cases of local drug delivery, we can see about 2% of minocycline or 50 micro or microliter of intraoperative apply should be used for the proper resolution of inflammation. And moving on to the laser has been recently advanced technique which has been found out to the reduction of pocket depth and attachment levels, resolution involvement and plaque index score also. So with the help of laser, we can go for photodynamic therapy around the implant surface to reduce the pocket or to reduce inflammation also, using a method called as active application of photosensitizers using an betadine blue or povidone iodine solutions. This is called as APDT method of cleaning the implant surface. And surgical treatments involved combines the concept of non-surgical method and lasers also. More or less in many conditions, the combined treatment methods has been approved as a best way than a single treatment approach. In access surgeries, we can be going for apically reposition flap with the help of laser and other kind of detoxifications and managements. In this thing, we can see about like 5 major defects, like one wall defect where single wall is evident, and two wall where two wall is evident, and dehiscence where the buccal surface of the bone is like completely broken off, and in 3 1 and 4 wall all the walls are evident, only the missing of wall will be like 1 and 2. In 4 wall defect, you will be going for a regenerative of approach using a bone or bone substitute. In 3 wall and in dehiscence case, you will be going for the regenerative therapy with the membrane. In 2 wall and 1 wall, you will be going for a guided bone regenerative with additional method of resective osseous surgeries also. So with apical reposition flap, when mechanical debridement and chemical detoxification of 5% hydrogen peroxide and 0.9% of sodium chloride with the help of EROAG laser, we have been found out a 6-month post-operative study, a reduction of pocket depth from 6.79 to 4.32 is evident, and bleeding of probing has been reduced from 100% to 14.3% has been proven. The resective osseous surgery has been proven to be evident only in the case of suprabony and infrabony defect also, and not suitable for regenerative surgeries. And moving on to the implantoplasty is like the removal of the implant threads, which are a major site for the deposits of calculus or plaque, which causes inflammation also. Upon implantoplasty, we have been found out the GBR and the GTR placement has been proven a better site for osseointegration also. So the regenerative approach has been involved usage of xenograft, enamel matrix derivative and platelet-derived growth factors and platelet-rich growth factors also has been proven at the clinical attachment level gain of about 5.29 millimeter and plus or minus 3.59 millimeter also, and radiographic bone fill from 3.30 to 4.75, which is like 1 to 1.5 millimeter bone fill has been like proven with the help of enamel matrix derivative and platelet-derived growth factor and combinations also. The soft tissue augmentation also has been proven sound with help of free soft tissues, acellular dermal matrix. Upon moving to the guided bone regeneration, we can see the dense or expanded polytetrafluoroethylene membrane has been used and has been proven of 50 to 100% range of bone fill as evidently proven. With addition of the non-surgical and surgical method, the bone fill technique of GBR, GTR can be approached for the better implant healing or the implant site development also. And the maintenance phase has been like involvement of cumulative interceptive supportive therapy, which has been found by Lang et al. This involves mainly the reason for the disease and the management of the disease only with the help of the reasoning or diagnosing the conditions of the disease also. So the 5 major facts included in this supportive therapy is the presence of plaque must be assessed, the bleeding tendency of the peri-implant tissues must be assessed, the pus discharge or suppression must be like evaluated, the peri-implant pocket must be assessed in the regular interval of time, and radiological evidence of bone loss must be like evaluated by the repeated recall of the patient, and maintenance therapy should be followed. And going on to the end part, we will be seeing that the peri-implant disease are the treatable disease. Only the factor is that we must find out the reason for the disease and manage the reason accordingly. Here we must be focusing towards a gram-negative anaerobic bacteria primarily, and the rational and the combined treatment approach must be used, and the supportive treatment program, that is cyst, which is found by Lang, must be like initiated also, and routine recall for the patient and proper maintenance of the oral hygiene must be like approach. So these are my references taken to make this preparation. So please go through office, and very much thank you for listening to the slide. If any doubts, you can approach for the reference stuff. Thank you.